Bismillahirrahmanirrahim. Our lecture today about overdenture. Overdenture is a removable partial denture or complete denture that covers and rests on one or more remaining natural teeth, the roots of natural teeth, and or dental implant. It is also called hybrid prosthesis, telescopic denture, overlay denture. This is the overdenture with bar attachment. It is like a conventional denture, but it is thinner in some area, and thus it may be constructed from high impact acrylic resin or cast chrome cobalt. In some cases, or in most cases, we make endodontic treatment, and the filling which may be used is Jata Persia, not silver point. The canine are the most frequently selective abutment for maxillary and mandibular overdenture, and then second premolars, maxillary central incisors, molars, and molar root. Mandibular incisors, first premolar and maxillary lateral incisor, I use less frequently. Two canine and two second premolar abutment are the most common pattern for four abutment. These four abutment and three abutment and two abutment and one abutment. Indication of overdenture. Overdenture is indicated when the remaining teeth are unsuitable as partial denture abutment because of position, angulation, or state of the crown, and also is unsuitable for fixed. Overdenture are preferred treatment modality for elderly patients with few remaining teeth. Also, it is used for young patients. Overdenture may be used as effective prosthodontic mean for correcting difficult indentation between the two dental arch and for treating dental disharmony. Also, it can used in cases with attrition, erosion, or abrasion. For patients with congenital or acquired intraoral defects, also to increase retention and stability. Patient with radiotherapy treatment to avoid extraction. With implant, can use with implant. This is case with attrition teeth. We can extract the hopeless teeth and make preparation for the teeth which will be used as abutment for overdenture. Contraindication Contraindication for using periodontal involved teeth as support include failure to establish sufficient zone of attached gingiva, excessive reduction of adjacent residual ridge as a result of osseous defect, teeth with grade 3 mobility. Also, the contraindication for endodontic treatment. The expense, the time required, and the additional procedure are of concern. Advantages of complete overdenture. Number one, preservation of the residual ridge by preservation of the tooth. Maintenance of proprioceptive response because we preserve the periodontal ligament. Support also retention, psychological advantages for the patient. Overdenture and each abutment can be cleaned by the patient more easily than fixed denture. Overdenture can really be converted to complete denture by relining or repair. These advantages of complete overdenture cures breakdown of overlaid teeth, uh, and we can overcome this problem by home care, follow up to the dentist with the dentist, and application of stannous fluoride. Bony undercut, and this is problem in insertion and removal of the denture. We can make relief and put soft liner to increase the retention. Encouragement of interocclusal distance by using coping and attachment. Aesthetic may be severe. Periodontal breakdown of the abutment teeth. This is the undercut, which is a problem to the patient in insertion and removal of the denture. We can cut the periphery to the level of undercut, but the peripheral seal will be lost. The surgery cannot be made because it is buccal plate bone, and we can make relief and put soft liner. These cures restorative diagnosis and treatment. Coronal amputation is the first step of restorative of treatment. Goals of the procedures are to minimize the stress on the abutment and maximize support for the procedures. For this reason, the dome-shaped abutment is usually advocated. The teeth with class 2 degree of movement can be used, and the movement will be reduced by reduction of the crown. Indication for the coping and abutment with gold are restoration of lost form and contour of the tooth because of caries or wear, and preparation of the abutment for an location of the remaining teeth is very important, as said before, insofar as support of the overdenture and preservation of the alveolar bone are concerned. These are most useful in area of maximum occlusal force and resorption potential. The anterior aspect of the residual ridge, especially in the mandible, is more susceptible to change. So canines and premolars are valuable teeth to preserve in this area. Diagnosis and treatment plan, periodontal diagnosis and treatment. In the long-term use of overdenture seems to be the high incidence of periodontal disease. A comprehensive periodontal examination is necessary to select the abutment teeth. Periodontal defect must be recognized and treated. Teeth with a calcified canal should be diagnosed before the access preparation. The aesthetic is very important. If the aesthetic is not important, we can remove the crown before endodontic therapy. Abutment selection. The critical factor in the selection of the abutment teeth for complete overdenture appear to be the status of abutment supporting tissue, consideration should be given to the abutment location and the number distribution. Ideally, the abutment teeth should present minimal mobility, have an acceptable bone support, and be amenable to periodontal. Accurate determination of the pocket depth by diagnostic radiograph it is needed to make a periodontal diagnosis. The width of attached gingiva is very important, buccally and lingually. Grafting of soft tissue can be used to make adequate band of attached gingiva. Mobility of the teeth. Many periodontal involved teeth are mobile after the crown is amputated. The crown root tissue is greatly improved and most lateral threads are removed. Prosthodontic diagnosis and treatment. Preoperative prosthodontic diagnosis should be accomplished through clinical examination and mounting studies cast. Adequate spaces for the overnature must exist in all planes. Inter-arch space is determined to ensure that there is room for the abutment as prepared. Study casts are helpful in diagnosis of area of bony and soft tissue undercut. Results often are better if approximately teeth such as canine and first premolar not selected. They do not provide more support and stability than one abutment. Typically, adjacent abutments are more difficult for the patient to clean adequately, which may compromise oral hygiene, and the prognosis of the one root is better for overdenture. They also increase the movement under the movement of the denture and more difficult to position denture teeth on overdenture. This is the bony support for the root. When the bone equal 2/3 of the root is better for using as abutment for patient selection. Uh, as before, we said on patient selection, there is uses of overdenture concept in other areas like congenital and acquired defects. As cleft palate, microdontia, amelogenesis imperfecta, dentinogenesis imperfecta, partial anodontia, and traumatic loss of many teeth. It is important to use these treatments in these cases. Partial overdenture, we can use the overdenture as a partial and make anterior abutment support or posterior, and this increase the supporting and retention of the denture. Use of delayed teeth in immediate denture. The technique employed is similar to that of the immediate or transitional denture. The only difference is that teeth to be overlaid are contoured differently on the master cast than teeth that are to be extracted. On the day of insertion, before the other teeth are extracted, the overlaid teeth are reduced in the mouth to desired height and contour. This reduction is only an approximation. After a suitable interval When wound healing is complete, the teeth are given to their final contouring, coping fabricated if indicated, and the appliance either refitted or remade. The various techniques for preparation of the abutment. Number one, simple tooth modification and reduction. This technique is often used in patients with severe abrasion teeth. Minimum tooth preparation is required because of the presence of a great deal of interocclusal distance. Teeth or prominent soft tissue undercut should not be engaged with overdenture. Retention can be improved if desired by placing soft liner into tooth and more tissue undercut. Number two, tooth reduction and cast coping. This is necessary because sensitivity or scarce control. The approach is possible only when the teeth have an adequate and a good periodontal prognosis. Because of this method, there is only a minimum reduction in the crown root ratio. Because of the minimum reduction in the coronal height, there is limitation of this technique. Adequate interocclusal distance must exist to allow for encouraging on the available space. Violation of a vertical dimension is able to occur with result being poor aesthetic and failure because of the patient tolerance. The technique number three, endodontic therapy and amalgam plug. This technique is indicated when there is normal coronal height to the teeth and normal interocclusal distance with little or less vertical dimension. Here, in order to create enough space for overdenture without opening, the vertical dimension the teeth must be reduced, usually to the gingival level or 2 millimeters above the gingival level. Because of this reduction, endodontic therapy is almost necessary. It is here that when hypermobile teeth, the periodontal therapy promises a very favorable prognosis. Number four, endodontic therapy and cast coping. Here, the procedure and indications are almost similar to the technique endodontic therapy and amalgam plug, with the exception that casting is placed on endodontically treated teeth instead of placing simple amalgam in root canal. The casting that is made is usually a shallow dome shape. Retention is gained from a short post is placed within root canal. Number five, endodontic therapy with the cast coping utilizing some form of attachment. And we come to this point later. Here, two canines. Here, two canines, but with peritoneally involved and must be treated before. This also two canines, more better than the other slide. This abutment preparation with coping. This long coping and short coping. This is with amalgam plug. This preparation for abutment with coping and attachment. The preparation like dome shape and elevate above the gingival level about 2 millimeters. We make reduction and make root canal with the coping. This involved teeth burden. This with coping and attachment. Rotherman. Um, when we come to attachment, the fifth technique is reserved for the situation in which not only stability is desired, but in which the significant improvement in retention is desired. Because of the added time, cost, and risk, this procedure should be reserved for patients with favorable prognosis. Two main types of attachment shall be discussed: the stud bar attachment and there is other attachment, the magnet and telescopic crown. Stud attachment, most of the stud attachment are simple in design. First, the definition of attachment is a mechanical device for fixation, rotation, and stabilization of the prosthesis. A retainer consisting of metal receptacles, matrix, and closely fitting part matrix. The female matrix component, which is usually contained within the normal or expanded contour of the crown of abutment tooth, and the male matrix component is attached to the pontic or the denture framework. Most of the stud attachments are simple in design, consisting of male stud type that is soldered to the base, the base of the coping, and also the female portion can be soldered to the base in other cases. The base of the coping covering the appropriate tooth stump, usually having a post extending into dondically treated root canal. Fixation is achieved by a female housing that either embedded in the acrylic or an overdenture, or soldered to substructure in the overdenture. The female housing can be rigidly attached to the male and classified as non-resonant attachment, not permit movement. It could also be designed with a spring load or some other engineered style to provide for controlled movement and therefore classified as a resonant attachment. There are many stud attachments like Rotherman, this attachment, Schubiger attachment, Interfax attachment, and the new one, the new attachment, era locator, equator, pole and socket, and O-ring attachment. This is Dutch attachment. Now for part attachment. There are many attachments available for use today. The purpose of the bar attachment are splinting of the abutment teeth and the retention and support of the prosthesis. Bar attachments are also indicated when the abutment teeth are non-parallel. The bar follows the curve of the alveolar process and is seated 2 to 3 mm above the crest of the ridge or attached to the gingiva. Bar attachments are of two types, bar unit and bar joint. Bar unit have rigid fixation where there is no movement between the bar and the overlying sleeve and therefore can be classified as tooth-borne. Bar joint permit rotational movement between the sleeve and the bar, utilizing more of the residual ridge support. The bar is between two teeth and the sleeve or clip in the fitting surface of the denture. This, this stud attachment, a bar with stud attachment, bar, bar with Schubiger attachment, which is used with non-parallel abutment, like this. This magnet attachment. Magnet retention is a popular method of attaching removable prostheses to either retain root or osseointegrated implant. The magnet is usually cylindrical or dome-shaped, attached to the fitting surface of the acrylic resin base of the overdenture, and the magnetic keeper cast to the metal coping cemented to root surface or screwed over the implant fixture. This magnet keeper although there are many advantages for magnet, which include ease of cleaning, ease of placement of the post dentist and patient, automatic reseating, decrease in the horizontal stress transmission and retention that is not reduced with use. Magnets have poor corrosive resistance when exposed to oral fluid and therefore require encapsulation with inert alloy such as stainless steel or titanium. This denture with attachment, female portion, this attachment is called Rotherman attachment. This abutment with this for impression of the coping. We need rubber band, copper band, and put in it silicone impression material and post and impression, right like this. The last type of attachment is telescopic attachment. The scopic overdenture is removable cross-sector to fit the overnatural teeth or implant with that portion of the overdenture over the natural teeth fitting like a sleeve. These supporting abutments were reduced and restored with metal coping called primary coping, which are cemented on the abutment. The size of the primary coping may be short or long, and may be designed to provide support only or to provide both support and retention. Secondary coping or sleeve may be special metal thimble or porcelain fused to metal restoration fitted over the primary coping and is at the tissue side of the acrylic denture base. And we can use polyether either ketone pick as the scopic denture, and also we can use chrome cobalt material. And we can use other materials. This pick, and this is a primary coping. This denture secondary coping is also on the denture secondary coping on the abutment coping. This metal also the secondary coping on the denture, primary coping on the cast on the non. This impression for overdenture is Oral hygiene is very important. We can use dental floss or small brush for cleaning. And the follow up with the dentist is very important also. This magnet, um, the magnet is attached to the fitting surface of the acrylic resin, and the magnetic keeper attached to the coping cemented to root surface or implant fixture. Overdenture. This complication of the overdenture gingival involved caries, recession, plaque accumulation, and he now will be with submerged root, which is root reduced and under the level of the alveolar crest with 2 millimeters. We make fill-up first and then reduction endodontic treatment. This is one of the technique, and submerge the root under the soft tissue and above the crest of the level with 2 millimeters. Alveolar bone resorption is a significant clinical problem. The average reduction of the residual ridge after tooth loss has been estimated to average to 0.5 milli per year. Maintenance of alveolar bone is thought to be dependent on the tensile stimulation provided by periodontal ligament during masticatory activity. Alveolar bone loss may result from lack of the stimulation because of the absence of teeth. Therefore, the only non-reliable way for prevention alveolar bone loss and maintenance of masticatory proprioception is by prevention of tooth loss. Overdenture concept is an effort to preserve alveolar bone by retaining natural teeth, which may or may not be endodontically treated and constructing denture directly over them. Periodontal disease curves and the expense entailed have annoyed the overdenture concept. It is because of these disadvantages that a simpler method of root retention was sought, and the concept and practice of submerged root retention have evolved. The root of the tooth is served 2 millimeters below the level of the alveolar bone, and the root or roots are covered completely with gingival tissue flap. The advantages of submerged root procedure: preservation of the alveolar ridge, increased denture stability, maintenance of proprioceptive response, inexpensive procedure, no need for special home care. The teeth selected for submersion should have the following criteria: no more than 1 millimeter horizontal mobility, no infrapony pocket, sufficient healthy mucogingival tissue, supporting alveolar bone equal to nearly one-third of the length of the root. The teeth have a small closal table. Adjacent teeth should not be present. Teeth should not have severe pony undercuts. The technique and also adequate thickness of cortical plate. Technique of root submersion. Preservation of vitality of the bulb in the residual root. Number one. But necrosis may be occur and inflammation. Endodontic of the residual root, it is very important. It is the most suitable method. Endodontic treatment of the root with extracted and reduced, and then replanted and submerged. And here ankylosing may occur. Valvectomy is performed in the residual root and submerged without root canal therapy, without filling. And here also inflammation and necrosis may occur. Failure of the submerged root surgical causes insufficient reduction in root height, improper contouring of the retained root, that the effect is to produce a more rounded ridge instead of the boxy one. Incomplete removal of clavicular epithelium, which delays the healing. Insufficient tissue for perfect closure. In these cases, the root will be appeared in the oral cavity. The prosthetic causes abnormal denture pressure from ill-fitting denture bases, inadequate balanced denture occlusion. Here we make flap and then make root canal treatment and reduction. In the replantation, we remove the tooth and make the root canal outside the oral cavity and then put again replant in the oral cavity. And this is the teeth or submerged root after finish of the method or after finish of the replantation. Here, after some time, we can see that the root can appear in the oral cavity, and this is a problem. Now we finish the subject. Thank you.